Good evening. Thank you for joining us for the 2025 Immunisation End of Year Update. My name is Phoebe James. I'm a Professional Development Officer with the Hunter New England and Central Coast Primary Health Network. Before we go any further, I would like to acknowledge the traditional custodians of the lands that I live and work on. For me and the wonderful team joining me this evening, that is Awabakal and Warramai land, and pay my respects to elders past, present, and any First Nations people joining us this evening. Just some housekeeping. We have some Slido questions peppered throughout our presentations this evening. We're trying to gather information around how confident you are in different things so that we can tailor our education next year appropriately. The questions, as always with Slido, will pop up on your right-hand side. So just answer those as they come up. Again with Slido, at the end, the evaluation. If you want your certificate, I need you to fill that in because with the live stream platform, I can't see if you've actually attended, so I use Slido and the evaluation to gather that information. So if you need a certificate, which you don't require to log your CPD hours, but if you would like one, please fill in the evaluation. At the end, we will be having a little Q&A session, time permitting. However, we do have the Brains Trust in the background on Slido answering your questions as they come through. So they do get lonely, so please make sure you send through as many questions as you like. It is now my great pleasure to introduce the one and only Sharon Saxby, Clinical Nurse Consultant with the H&E PHU. Thanks, Sharon.
Thank you, Phoebe, and thank you, PHN, for hosting us, as always, beautifully. So welcome, everybody. Thank you for joining us for a night of chatting about immunisations. We understand it's a very busy time of the year, and you've probably taken off time for Christmas shopping, so we really appreciate your sacrifice for us tonight. We are going to be presenting some great information to hopefully assist you in preparing for your vaccines for the summer heat and for protecting your clients who are going to be participating in all those summer activities that usually include outdoors. We'll be talking about JEV vaccination, cold chain management. Jodie's going to have a chat about ensuring that you can catch up all your kiddies who are overdue vaccines over the holidays. Kirsty's going to be talking about how you can protect your clients when they go travelling, and we'll touch on rabies and school vaccination program and what's to come in 2026. I would like to say a really big shout out to all of those providers out there that have managed to navigate best practice and Prevnar 20 onto AIR. It's been a schmozzle, and we understand that, and to thank you for all of those who have figured it out, and continue calling us if you do have issues. So sit back and enjoy our presentations. We just have a Slido question, so if you'd like to take the time to answer that first question on how confident are you making Japanese encephalitis vaccine recommendations for your clients. This information is really useful for us. Okay, so just give that a few more seconds. So really interesting. We have a really smooth range of responses there. So let's see if we can help you with our next presentation. So keep answering those questions. We're going to have a little bit of an update on Japanese encephalitis vaccination. So in the past, we have talked a lot about Japanese encephalitis vaccination, but I thought tonight we'd go a little bit deeper and talk a little bit more about refreshing everyone about what is Japanese encephalitis virus. It's a flavivirus, and it has the same serocomplex as dengue fever, West Nile virus, and yellow fever. The fact that it's so similar makes it really difficult sometimes to actually diagnose which flavivirus the patient may be displaying symptoms of. It was first reported in Japan back in 1871, and it mainly affects children in endemic countries. The symptoms of Japanese encephalitis, most people will show no symptoms at all. 10% of those infected may experience symptoms such as fever, headache and vomiting, which you would expect with an encephalitic disease. And 1 in 200 of those infected will actually develop encephalitis, which can cause symptoms such as stiff neck, confusion, seizures and coma. Survivors of serious illness really run a risk of permanent neurological damage and or death. So it is a really potentially serious disease. As we say, most people get no symptoms at all. So understanding how many people have actually had Japanese encephalitis can be a little bit difficult. We'll cover that a bit later. There is no specific treatment for Japanese encephalitis. Okay? Patients will often need hospital support and sometimes intensive care, but there is no active treatment. So prevention, obviously, is the best form. And of course, New South Wales Health have a great fact sheet on Japanese encephalitis. How is it spread? It is a zoonosis of pigs and water birds. The Culex mosquitoes transmit the virus between these different animals. Now, the water birds are considered a maintenance host, and pigs are an amplifying host for JE virus. Following infection, the virus replicates in these vertebrate hosts and causes a transient high-level viremia, which is capable then of infecting the biting mosquitoes. So the mosquitoes bite these animals and become infected, and then of course the mosquitoes bite us. So humans are just an incidental host, not amplifying hosts, and we can't actually transfer JE virus from one person to another. Obviously then the disease is more common if you live close, or your risk of being infected is more common if you live close to these hosts. It's fair to say that areas with established JE immunisation programs may not report many cases in humans because the majority of presentations are asymptomatic, but people who live or visit these areas are still at risk. So we need to be alert for the risk of JE infection at all times. If there's a risk of being bitten by mosquitoes, there's a risk of JE. How do we know where JE is? Because we have high risk areas and we have areas that are not so risk. We do a lot of surveillance in New South Wales, and this usually goes from November through to April, and this includes testing our chicken sentinel flocks, mosquito trapping and testing, and opportunistic sampling of feral pigs. Different jurisdictions have responsibility for checking the chicken flocks and mosquito trapping and the feral pigs. So we are now considering that JEV is endemic in southeastern Australia. And there's a lot of high-risk LGAs which are eligible for free vaccination, and we'll talk about that in a minute. So what have we seen? So since 2021 and 2025, we've actually seen a total of 19 cases in New South Wales of JEV, and we've had 4 deaths in that. As you can see here, we only started measuring in 2021 purely because we just didn't see JEV in New South Wales prior to that. We're assuming that it's come down with a whole lot of wet seasons that we've had, migration of water birds, and here we have it. Typically, this is a disease that we look for in tropical countries. It's been a travel vaccine for a very long time, but not in New South Wales. So we can see now that JEV is in New South Wales to stay. Just after that first cluster of infections back in 2021, New South Wales Health decided to do a sero survey to better understand how many people have actually been infected, as we spoke about, because many remain asymptomatic in the initial outbreak. So the sero survey was taken samples from 5 regional towns. You can see them there: Balranald, Corowa, Dubbo, Griffith and Temora. So they had a good sample of 917 participants, of which 80 were seropositive for JE-specific antibodies. But that's 8.7. But you can see in that area back then, we only had a much smaller cluster of cases that we knew of. So 80 actually were seropositive. People aged 65 and older had a higher seroprevalence, as did males. And of those, there were 12% of Aboriginal and Torres Strait Islanders were seropositive. So the rate was a little bit higher in our Aboriginal and Torres Strait Islander people. So that's really interesting, highlighting the fact that we don't really understand how much JEV is out there. You may be aware that New South Wales Health have issued a media release recently talking about the fact that already early in this season in Victoria and Horsham, so even further south than New South Wales, there's been a detection of JEV in mosquitoes, and there was a detection of Kunjun virus in chicken in Cowra. So these detections are actually an early signal of increased mosquito virus risk of this season. There's a prediction of high rainfall and forecasts of above average temperatures this summer, which of course are going to lead to an increased level of mosquito activity, which leads to an increased risk of JEV and other encephalitic mosquito-borne viruses. In New South Wales, this will be typically west of the Great Dividing Range and in northern New South Wales. How do we protect ourselves? Obviously, the best way to avoid Japanese encephalitis is not to get bitten by mosquitoes. We have a lot of people in our communities that say, I never get bitten by mosquitoes. But science would tell us that we all probably get bitten by mosquitoes. Some just don't react. So we don't notice that itchy bite, we don't notice the lump, we don't notice the bite at all. But most commonly, most people get bitten. So we need to protect ourselves. Wearing loose, light-coloured, long-sleeve shirts and long trousers, enclosed shoes, applying good mosquito repellent, DEET, or ones containing picaridin. Get rid of those water reservoirs around the house. Just remember that tight, long-sleeve clothing, mosquitoes can still bite through that. And of course, vaccination, which is very effective. So recommendations for vaccination. In New South Wales, we have a program that offers free Japanese encephalitis vaccination for people aged 2 months and older who simply live or work in any of the high-risk LGAs. We'll cover those in a minute, but there is a great fact sheet on Ministry of Health, if you want to look that up, that outlines all of those LGAs. Just remembering these are LGAs, lots of different suburbs in those LGAs. A free vaccine is also recommended and available for people who live in any part of New South Wales, but who work or live or visit piggeries, pork abattoirs and pork rendering plants. If they work directly through mosquitoes, like the people that go out and collect mosquitoes for surveillance, control and management, environmental officers, etc., and all diagnostic and research lab workers who may be exposed to the virus. So they are eligible for a funded vaccine as well. So please don't question people too much. Be asking simple questions and offer a vaccination. Other people are also recommended for vaccination, but it's not necessarily free or funded. A very interchangeable word here. So they're also funded for people planning to travel to a JE high-risk region in Australia. They don't live or work there, but they're travelling. You might recommend a JE vaccine. Travellers to endemic areas outside of Australia during the JE virus transmission season. Once again, that comes back to our travel vaccines. Booster recommendations are made for some people. Go back and refer to your handbook, because the recommendation for boosters depends on the age of the person when they received their primary vaccination course and the vaccine that was used in their primary course. So there are different qualifications for whether they need a booster. Just remember that the handbook is our guide. Areas of LGA, areas of high concern, as you can see here, it's actually west of the Dividing Range in New South Wales, with the exception of a couple of areas in the north and the Upper Hunter. So west of the Dividing Range, anywhere past that is eligible for a free vaccination. Once again, please don't hesitate. And a big shout out to all the people that have been really proactively vaccinating, especially in places like Tamworth and Narrabri, Inverell, Moree. It's fantastic work and please keep it up. So who is giving Japanese encephalitis vaccination or ordering it? We can see that GPs are the biggest requester or orderer of Japanese encephalitis vaccine, which is fantastic, followed by pharmacies and state health departments. Now, state health departments and public hospitals are probably vaccinating staff. We also want to be getting out to the general public, and especially our council workers and people who work outside all the time. But let's face it, everybody goes outside at some point, and we have mozzies in the house as well. vaccine administration, you can see here that it wanes and it dips, etc. It's been really lovely to see that in the last few weeks, on the right of that graph, that we've had a real uptick in doses administered. This is doses that have been recorded on the AIR. So potentially it's a little bit higher with some doses not being transmitted to air. But we are at the very beginning of the mozzie season. So if we need that to actually peak further than that previous group there, that high graph. And this is a really interesting chart. Even though we can see an uptick and we think lots of vaccine have gone out, if you look very over in the right-hand column, that's the number of people per 1,000 in those areas. So in Narrabri, even though they're doing really well, it's only 86 people per 1,000 that have received a JE vaccine dose. Moree, 112, and Tamworth, only 40.5 have received per 1,000 a vaccination dose. So there's more work to be done, and leading into the season, please ask and recommend vaccines. Have them in your fridge, ready to go when people ask. And just remember, we can do people from 2 months of age. If we have pharmacists online, just remember that if you have someone under the age of 5, please recommend that they go back to their GP or their AMS to get their vaccination. What do we give? 2 different vaccines. We have Imujev, which is the preferred vaccine. Just a warning though, Imujev is a live vaccine. It's registered for people 9 months of age and older. It's a single dose. It's given by subcutaneous injection. Remember, live vaccine, you need to check air, make sure they haven't had another live vaccine in the last month, and just warn them that they can't have another one within the next month. We have Jespect, which is an inactivated vaccine. These are able to be ordered in limited doses, limited numbers from the vaccine centre, because they want you to reserve those for the people that cannot have Imujev. It's registered from people from 2 months of age and older. It is actually a 2-dose course. So just a bit tricky. So 2 months to 3 years, they only need half the dose, so 0.25 of a mil. 2 doses, 28 days apart. 3 years and up to adults, it's half a mil, which is the full dose in the syringe. 2 doses, 28 days apart, and it's by intramuscular injection. So extracting the 0.25 mil, you need to be a bit tricky and have a metered syringe on there and just draw up your 0.25 of a mil out of the other syringe. Of course, the other things are that, Imujev is being a live vaccine. The only contraindication truly is an anaphylaxis after a previous dose or anaphylaxis after a component of the JE vaccine. But because Imujev is a live vaccine, it's of course contraindicated in people who are immunocompromised and in pregnant women. Women should also avoid pregnancy for 28 days after vaccination. Breastfeeding women, there's a bit of a precaution around there because it's not known whether that virus is excreted in the breast milk. So for those people, we're going to use Jespect. So we use that for our immunocompromised and pregnant, and in pregnancy and breastfeeding, it's not usually recommended, but if they're at risk of requiring JE, so they live in one of those high-risk areas, Jespect is a recommended vaccine. There's been no indication of adverse outcomes of pregnancy attributed to Jespect, but interestingly, JE virus infection during first and second trimesters has been associated with a high risk of miscarriage. So just go with caution, and getting vaccine is better than getting disease. Refer always back to your handbook, okay, because it's full of all the information that you need. So what can you do to promote JE vaccination within your community and your patients? I suggest make it part of your conversations. You're having a conversation with somebody, just incidentally bring in, have you considered Japanese encephalitis vaccine? It's funded for you, it's available, let's talk about that. Displaying posters and brochures within your waiting area. Using social media. Most places these days have social media in the form of a Facebook or Instagram account. The New South Wales Health have some fantastic social media tiles and posters and brochures free for you in the Japanese encephalitis toolkit, which is quite available online. And educate all of your staff about JEV and the vaccination eligibility. In lots of conversations that I've had around the traps with people who have ordering vaccine but have not given a great number, there's been reports from patients that they can't quite get past. Either the reception staff don't know that they're offering it or don't know that they're offering it to children. So make sure, even down to your receptionists, that they are fully aware of what vaccine is eligible for who and what you are offering. Educate your nurses, your doctors, make it part of everyday conversation. Because if we can minimise that risk, which is increasing as the weeks go on now, then that's a great job done. All of this information is available online. So thank you, and look forward to seeing a greater uptick in ordering of JEV vaccine and administration. Next, we're going to have Lisa.
Hi everyone, my name's Lisa. I'm quite new to the immunisation team. I've been here for about 12 months. And tonight I'm going to talk about cold chain management. So, no cold chain, no immunisation. This says everything that we need to know about cold chain, managing the cold chain. We need to keep that managed to keep immunisation rolling on. And I've lost my notes. Oh, no, they're here, sorry. So no cold chain, no immunisation, and as providers we need to ensure that we have everything in place to maintain the cold chain because, no cold chain, no immunisation. Okay, so global immunisation has saved at least 154 million lives over the past 50 years. And when we look at how the cold chain has supported vaccination, this has required hundreds of thousands of pairs of hands, fridges, freezers, and millions of eskies and ice packs. And when we look globally at the challenges of maintaining the cold chain, we see things such as lack of reliable electricity, poor roads, difficult terrain, and unstable contexts. The picture in the bottom right is of a vaccination campaign that I worked on in South Sudan. What I knew about cold chain when I landed in South Sudan was not a lot, so it was a very steep learning curve. But you can see we're travelling out on a very rough road or lack of road, which got even worse in the wet season. And you can see the middle ute there's loaded up with eskies, covered in tarp to try and keep the dust out. The average temp was 45 degrees. So very, very, very challenging. But Hunter New England is not without its challenges in terms of managing the cold chain. We have rural communities, we have workforce shortages, we have transient staff, frequent power outages, we have lack of backup generators for many facilities out there, fridges malfunction, we have natural disasters, and we're already seeing these fires 3 days into summer, and many, many competing priorities. We know for you guys out in your facilities that cold chain is one small part of what you do, and we recognise that it's very, very difficult out there at times. So why is protecting the cold chain so important? So it's a carefully managed journey, these vaccines. By the time they've been manufactured and they reach us, they've already been through a long journey. They are expertly packed and transported in temperature-controlled vehicles, supported by continuous monitoring systems and cold chain technologies. Vaccines are a finite and valuable resource, and mass wastage can mean that services miss out, and that's not only locally but globally, leaving vulnerable people at risk to vaccine-preventable diseases. Quality and efficacy. Strictly maintaining that cold chain at 2 to 8 degrees and striving for 5 protects their quality so that it remains safe and effective for every patient, every time. And trust and community confidence. Our patients place a great deal of trust in us. They rely on us to provide vaccinations that are safe, effective, and handled with the highest standards of care. A recall requiring patients to be vaccinated is always the last resort. It's costly, it's disruptive, and more importantly, it can significantly undermine community confidence. And at a time where vaccination rates are declining and vaccine misinformation is increasing, maintaining that trust is more important than ever. Let's have a look at cold chain management for the Public Health Unit immunisation team for 2025. So Hunter New England covers a region of over 130,000 square kilometres. So far for 2025, over 900,000 vaccines have been delivered to 446,000 people in our region. That is by you, and that's an incredible service, and we really appreciate what you do, and you should feel so proud of keeping your communities safe and protected. There are over 700 service providers that fall under us, the IMS team at the Public Health Unit. There's 670 kilometres between our Wallsend office and the furthest service provider. And with a small team of 4 CNCs and 1 fantastic RN, we really rely on you to manage your cold chains as best you can to keep your vaccines effective. Let's talk about your tasks in managing your cold chain. We know that daily tasks can feel repetitive and monotonous, but that consistent, careful monitoring prevents significant disruption to vaccine services when there has been a breach. So twice daily, manually record minimum and maximum temperatures each morning and evening and plot them on your Strive for 5 min-max chart. Check that your temperatures have remained between 2 and 8 degrees. If they're out of range, have a look at your data logger. Your data logger's your go-to. So your min-max, you're checking that twice a day, and then you're going to your data logger if there seems to be an issue, if it's above 8 or under 2. If you're confident that you haven't had a cold chain breach, reset your min-max. Every time you check your fridge, go ahead and reset your min-max. Do that for the person coming behind you, because if you've gone through and checked your data logger and haven't reset, and that poor person comes along and sees the same thing, they've gone and done a job that didn't need to be done. When you're at the fridge, this is a good time to have a quick check over everything. We often hear, if I have a cloud-based monitor or if I have a data logger that I can see, why do I need to use the min-max? Well, one of those reasons is that we want you to be having a look at your fridge and making sure that everything's running well. So when you're at your fridge, visualise that your vaccines are stored correctly. Make sure that nothing's out of the box. There's no light getting to your vaccines. We know that light can significantly reduce effectiveness of vaccines, so we want them to remain in their package until they're administered. Ensure you've got air circulating around your vaccines, and that vaccines only are stored in your fridge. We don't want to see egg sandwiches or cans of Coke in your fridge, even though they're nice when they're icy cold. Not in your vaccine fridge. Now is a really good time to review your stock and ensure that you're not over-ordering prior to your Christmas break. So your weekly tasks. So weekly, download your data logger, know your logger. We can scream that from the rooftops in the PHU team. There's nothing worse than trying to navigate a logger when you've had a cold chain breach in the morning of a clinic where you have 30 patients booked in. It's not nice, it's not enjoyable for you. Really get to know your logger and make sure that there's not just you, but there's 1 or 2 other people in your facility who know how to load that logger. Because as we know, if your fridge is going to conk it, it's going to do it on the morning of a big vaccine clinic that you have booked in. If you are the only person that knows how to do your logger, make sure you hand over to someone before you go on leave. That's always kind to do. And so when you're checking your logger, you want to have a look and make sure that your temperatures remain between 2 and 8 degrees. So review your graph, that'll give you a good view, and review your table of loggings. I'm going to reiterate, review your logger. It's not uncommon for us to receive months of logging that have been meticulously downloaded, which is fantastic, but no one's actually looked at them. And then they've reported 1 breach to us, and when we've looked back at months of logging, we can see there's been 4 or 5 breaches that were never actually picked up. Especially the case for cloud-based loggers. Set some time apart every week to go through and look at your previous week of logging and save it. Once you've saved your logger, relaunch it and make sure it's at the 5-minute intervals. Your annual tasks, you want to arrange for your fridge to be serviced once a year, complete your Strive for 5 audit, calibrate your thermometers and data loggers, your thermometers, your min-maxes by doing a slurry test, and change your batteries of both. Instructions for these can be found on the New South Wales Health Immunisation site or in the National Vaccine Storage Guidelines. You can contact us at the PHU if you need a hand finding them. Now on to cold chain breaches. So cold chain breach management for the Public Health Unit team in 2025. We've had 353 cold chain breaches reported so far this year. 154 of these are due to weather events. 62 of these were received over a 1-week period after a storm event in January. And looking at our wastage reports, Over 15,000 doses wasted over the year, costing around over $300,000. So what constitutes a cold chain breach? So any temperature over 12 degrees for longer than 15 minutes. This got me when I first started. I find it a little bit confusing, and we do have lots of questions about this one. This up to 12 degrees for up to 15 minutes is really just allow you to be able to pack some vaccines away, rearrange your fridge, bring old stock to the front and new stock to behind. It's really just a bit of a buffer when you need to get into your fridge. Anything above 12 degrees for any duration of time is a breach. Anything longer than 15 minutes, whether it's 8.5, 9 degrees, longer than 15 minutes is a breach. And anything below 2 degrees for any duration is a breach. Once you have your breach, give us a call, report to the PHU. If you're unsure, you can always call us for clarification or advice. Okay. What to do in a cold chain breach? If nothing else, pop a sign in your fridge and ensure that nothing is administered. That's the main thing we want you to do. That's the most important part if you have that cold chain breach. Don't discard any vaccines until you hear back from us at the Public Health Unit. Don't administer any vaccines until you hear back from us. Avoid transporting vaccines to another facility. We love and we highly appreciate your commitment to maintaining the cold chain. This often becomes really complex, and as a result, we often see further breaches during transportation or breaches of that fridge at the alternative site. People were wonderful in the January storm event, but we did see that vaccines were sort of moved from one facility to the other, and that other facility had a breach as well that hadn't actually picked up, and it got really complex to try and sort out what was happening with these vaccines. In the event that your fridge has malfunctioned, and that you do have another vaccine fridge, an alternative fridge that you can transport your vaccines to, we require evidence that the cold chain's been maintained during transportation, so either with your min-max or, if you can, even better, pop a data logger in your esky while you transport. We also need to see data logging of the fridge that you've transported your vaccines to. Any questions at all, you can contact us at the Public Health Unit, or you can go to the Hunter New England Immunisation and Allergy Immunology site. What do you need to send through to the Public Health Unit when you've had a cold chain breach? So your cold chain breach reporting form, this one can be downloaded off the H&E Immunisation website, or you can just contact us. We're happy to email you one through with some instructions of what to do. Please avoid using old forms. They don't have the latest vaccines on them, and it can be a bit of a back and forth. Your data logging, this is the most important and the most frequent part of a cold chain breach that we end up chasing. So top on the very left-hand side of your screen there is how we like to see your data logging. So we like to see it in those 5-minutely increments. Sending through a graph's great because that'll let us identify when you've had the breach, but we really need those 5-minutely intervals to be able to determine thermostability data. We need to know minimum temperature, maximum temperature, and the duration of your breach. We also need to see your min-max temperature chart and your cold chain certificates. So in summary, no cold chain, no immunisation. Cold chain management is just as vital as immunisation. Maintain your cold chain at 2 to 8 degrees and strive for 5. Record your fridge temperature twice a day. Ensure that you know how to download your logger and that someone else in your facility does. Quarantine your vaccines in a breach. Put that sign on the fridge, do not use, and contact the Public Health Unit IMS team for any vaccine breaches or questions. So that's it for me. Merry Christmas. Thank you from us for everything you do in the world of immunisation. We really appreciate what you do, your day-to-day work. It's really important, so thank you. All right.
Hello there. My name's Jodie Stevenson. I'm a clinical nurse consultant with the immunisation team. I was away last year, but I'm back this year with a vengeance. Just building on what Lisa was saying, not only do you need to know how to download your data logger, but we need you to know how to attach that bad boy to an email And we need data loggings covering just before the breach and at the end of the breach. Last week we got lots of cold chain breaches where people had downloaded their logger while the temperature was still 18, 19, 20 degrees. So we had no logging showing when the fridge had come back into range, so we didn't know exactly how long it was out of range. So please practice emailing yourself, your friends, us, email us your data loggings, and don't download your data logger while the cold chain breach is ongoing. No point. You need to wait till after the event. Okay, but that's not my topic. It's just a passion. Oh, I'm sad. I'm sad that only 65% are confident downloading your logger. So put that on your to-do list. Learn how to download your logger and attach it to an email. Okay, how confident are you at reporting an adverse event? How confident are you at identifying an adverse event following immunisation? Okay, we've got some work to do there. I can work with that. So, call us. So, an adverse event is any unwanted event following an immunisation, unwanted, unexpected. So we know that local reaction is an expected reaction. We know that fever, expected, feeling generally unwell. Hospitalisation, unwanted, we want to know about those. Extensive limb swelling, so you've got swelling from shoulder to elbow, from joint to joint, we want to know about those. Anything odd, you don't have to know if it was caused by the vaccine, you have to report it to us, we report it onto the TGA. You call us, we email you the link to the RedCap AFI site, and that's how you report an adverse event following immunisation. If in doubt, as Lisa said, call us. Okay, I want to talk about improving immunisation rates, team, not just for kids, but for everyone in our community. We, as nurses and doctors and pharmacists working in the immunisation space, are more vital than ever at countering misinformation and keeping our community safe. How confident are you at providing a catch-up vaccination schedule for your patients? That's a really good one. Oh, that's good. Oh. It's like a little roller coaster here, isn't it? Catch-up vaccinations are really tricky, and the catch-up calculator with the link in the Australian Immunisation Handbook is really tricky as well, because it tells you funded NIP vaccines as well as non-funded vaccines. So you'll see a bonus chickenpox vaccine in there, which according to the handbook is recommended but not funded. You'll see Men-B is often recommended but not funded. It's not always clear that it's recommended but not funded. I think maybe next year, based on this, we might have to do some workshops just on how to do catch-up vaccinations. That will be fun. Okay, improving immunisation rates. Why doesn't it want to move along? What have I done? Just slow. A bit like me. Okay. Childhood immunisation rates are the cornerstone of public health, right up there with clean water and housing. They prevent serious diseases and they reduce outbreaks in our communities. As nurses, understanding strategies to improve immunisation rates for our community safeguard our children's health, our community's health, and protect our hospitals by keeping people out of hospitals. This presentation aims to talk about some practical evidence-based approaches to overcome barriers, and by implementing these strategies, we can play a pivotal role in reducing morbidity and mortality associated with vaccine-preventable diseases. We're going to cover why immunisation matters, some of the common barriers, and some actionable solutions that we really want you to adopt in your services. And we want you to share your ideas with us so we can pass them on to other services as well. The strategies that we're going to mention here align with the National Immunisation Strategy for Australia 2025 to 2030. These are global best practices, but we know that you've got better ones. Okay, so childhood immunisation protects against life-threatening diseases like hepatitis B, like measles, whooping cough, meningitis. Think of your favourite vaccine. We did a quick scan here. For some of us it's rabies, some it's influenza, some it's Gardasil. High vaccination rates protect our community and reduce the risk of outbreaks. They contribute to herd immunity and they safeguard vulnerable populations that can't be immunised. Think of your people undergoing cancer treatment, stem cell treatment, can't be immunised, at risk. We need to protect everyone around them. And they lower our healthcare costs by keeping people out of our hospital. Sorry, one of the other favourite vaccines is the RSV vaccine, and I reckon any of you there with little possums would have your own stories about RSV. Immunisation programs have a proven cost-effective and safe history. They are essential for maintaining our community health. Decline in coverage since COVID-19 has made our role all the more important. We are trusted healthcare professionals. We are trusted providers, and we need to be proactive about engaging with our families and our communities and helping in the parental decision making. Never underestimate your value. So, research has shown some of the barriers to immunisation. Bear in mind, up to 95% of our community does get immunised. This is helping the small percentage that is struggling to get immunised. The barriers are cost, constantly comes up, access, scheduling difficulties, and vaccine hesitancy. Although vaccines under the National Immunisation Program are free, consultation fees at your surgery may not be. And there's indirect costs such as the transport to your service, the time off work to your service. And you know how Lisa was talking about cold chain? Imagine your family's taken the day off work to come and see you for their immunisations and you've had a cold chain breach, or you've left your vaccines exposed to light. Like, this is really important that we get this whole package right. There's also limited appointment availability and inflexible clinic hours. Most of us work 9 till 5, so we need to think of other ways we can encourage families into our services to get immunisations. Vaccine hesitancy is often driven by safety concerns, and misinformation. And those challenges remain high, and this is where our involvement as trusted professionals come in, and this is where we need to ensure that we are up to date with our skills and knowledge. Addressing the barriers to immunisation is a multifaceted approach that combines improving access, having effective communication with our family, and implementing strategies that help reduce those practical difficulties. So what are some of these practical solutions? We're talking reminder and recall systems. Even before that, we're talking your beautiful admin person reminding your front of your service that 6 weeks vaccines are due at 6 weeks. They're due 6 weeks to 3 months. They're not due 5 weeks and 4 days, because if parents come in, you then ring us to see, should we give them? And the handbook says vaccines are due from 6 weeks. So immunisation confidence starts with our beautiful admin support booking patients in. We've got 6 weeks to 3 months to get that first dose of vaccine. Of course, we want to do it as close to 6 weeks, but we're talking that 6 to 8 week mirror. A second one, you've immunised your bubby. See if you can book your appointment, their next appointment there and then for them in your clinic room. Or walk with them to reception and say, we need an appointment when Bubby is 4 months, when Bubby is 6 months, 12 months, 18 months, 2 months from today, whatever the schedule is, make sure that appointment is booked then. Because if you're like me, you've left the surgery, your work here is done, you don't think, what else did I have to do? Make sure you give all due vaccines at the one appointment. We're still having such low coverage of Bexzero or meningococcal B because services are declining to give the vaccines in combination. So declining to give it at 6 weeks, at 6 months, at 12 months. It's really important that we don't create barriers or vaccine hesitancy, that we administer all recommended vaccines at that appointment. On the proviso, we remind people that they need paracetamol. We remind people of what the expected reactions are. So parents, when they get a fever that night, they're not overly concerned because we've told them that bub might be grizzly. They may get a sore arm or sore leg. We've been open and transparent with the families. We also need to look at reminder and recall systems because these are one of the most effective tools that we have for improving immunisation rates. This is, you've made an appointment, mum's cancelled, follow up with mum and book the next appointment, the family or mum. Either through SMS, emails, phone calls, mail. We talk to overdue families and a lot of them didn't know that the vaccines were due. They don't know the schedule. That's our job. So you, in your service, need to implement a recall and reminder system. So a reminder that the appointment's coming up, my hairdresser can do it for me, the vet does it for me, remind them it's coming up, a recall after the event. For some reason, they've missed that appointment. Let's keep following up with the families. Let's look at immunisations at every appointment. We were looking at some babies today that had adolescents that had multiple appointments at the GP, but had still missed their Gardasil, their Boostrix and their meningococcal vaccine because no one had asked. These are 16-year-olds. Let's check on air to see what they're due every appointment. And make sure the contact details are verified and correct at every appointment as well. This will help when we ring and go, have you got an up-to-date contact detail? Mum's overdue or bub's overdue. We're really trying to get in contact with them. And let's have a team-based approach. It's not just going to be us, the nurses, that are going to improve immunisation rates at your service. It's going to be everyone. It's going to be your amazing admin support that are confident in booking immunisation appointments, confident in talking about vaccines. Every staff member needs to be involved in the promoting of vaccines at your service. There's a beautiful GP service at West Wallsend, and directly opposite them is the vet, and the vet has a big window saying free vaccines. We need to be able to promote vaccines openly and easily. Every staff member should be involved in promoting vaccines. Reception staff should be able to schedule appointments at the appropriate times and send reminders, while the nurses and doctors reinforce the vaccine recommendations during each consultation. We need to ensure that our staff are trained on immunisation protocols and communication techniques to ensure consistency and confidence in the information that's being provided. We are advocates for the vaccines. Embedding immunisation into routine practices, workflows, creates a culture where vaccination is prioritised and it's not an afterthought. This will improve our coverage and our patient outcomes. For those of us that had attended the Tamworth conference, when asked what we want in a vaccine, what we'd look forward to next, so many people said a vaccine for cancer. We have 2 vaccines for cancers now. Let's make sure that we recommend those vaccines with confidence and to everyone that needs them. So those 2 vaccines, hepatitis B, we give it to babies the day they're born, because if a baby's exposed to the hepatitis B virus before the age of 2, they're more likely to go on, an unimmunised baby, to go on develop chronic liver issues. That's why we immunise. And Gardasil vaccine, it's a single dose for most people now, boys and girls, because nobody wants warts on their genitals and nobody wants cancer in their I think I can say bottom, or throat, or cervix. So it's really important, each adolescent that you get into your space, check that they've had the appropriate vaccines, because these guys see you as a last resort because they're happy, healthy and fun out living. If you get them into your practice, make sure you check their vaccines. I feel like I'm yelling at you now. I feel really passionate about these vaccines. Communication and education, bringing it down a notch. So how are you going to know where to get this clear, confident information from? Because this is critical to addressing vaccine hesitancy. So what we say to our families are, today we'll administer your child's vaccine. So it's a presumptive approach. We're not, oh, are you here for vaccines? Oh, you've got 3, is that going to be okay? We're here to administer Bubby's vaccines today. Or, today we're going to protect Bubby from diphtheria, tetanus, pertussis, Hib, hepatitis B, polio, pneumococcal and rotavirus. This is really good. Do you have any questions? So this is taking a really positive and presumptive approach that we are confident in the vaccine recommendations, and we're normalising vaccination for mum. There's also motivational interviewing techniques. So asking open-ended questions. So if mum is a bit concerned or hesitant, ask, what are your concerns today? Or do you have any concerns today? But making sure we listen, we don't try and correct mum straight away, or family, we don't correct them. We ask, would you like me to give you some information about your concerns? I know we want to tell family, no, we've got the right information, but we need to make sure that the family wants to hear that. So it's really important, before you just try and correct families, say, would you like me to give you the correct information? Now on this slide, we've got Sky, sharing knowledge about immunisation. They have a course for health professionals on communicating about vaccines. They also have a range of fact sheets designed for families. So they have a fact sheet on why do we give birth dose hepatitis B. They have a fact sheet on autism and vaccine, explaining why there is no link between autism and vaccines. They also have a really good fact sheet just in case parents are deciding to decline vaccines at this stage. It's a fact sheet of what they need to look out for and when they need to be concerned and seek medical treatment. So it lists the diseases that the vaccines protect against, and it lists early symptoms. These are really good resources that you need to have on hand. The other one is your immunisation handbook. It's got excellent information about the vaccines. It covers the vaccine components. It covers when they're due, who can have it, who to have precautions. It covers expected reactions. On here, we've got Ausvac safety. Now, for those of us that have been in this for a little while, you may remember VaxTracker, born and bred in Hunter, New England, which we designed to promote vaccine safety for children under 5. VaxTracker is part of Ausvac Safety. So that's real-time vaccine safety data, letting parents know what's been reported. We're not hiding anything. We are putting it all out there. And the Science of Immunisation from the Academy, the Australian Academy of Science. You can no longer order the books, but there's an updated book available online, and you can print that out yourself. And if you've got a dot like we do, she'll laminate it for you, or bind it for you, sorry. So providing factual, easy to understand resources counters misinformation and empowers parents to make informed decisions. At this point, I'd really like to say, are there any questions? But I know that's really tricky. And we really need to be empathetic, because all families are just trying to do the best by their families. So we're going to have some families that may want to delay some vaccines. So they mainly want one vaccine at a time. We need to work with families to ensure that their child is immunised. Okay, so wrapping this all up. These are things that I'd like you to try and think about after our services. social media and your practice website strongly promoting immunisation. I'm just going to ask Sharon, is it the TAMS Facebook page, Sharon, that has the amazing videos promoting immunisation? Tamworth, if you're on Facebook, have a look at the Tamworth Aboriginal Medical Service. They've got amazing videos that their services have made promoting immunisation for their community. Monitor coverage rates using your practice data and respond to challenges. Reach out to your primary health network. Remember, we're the public health unit. There's the primary health network that can help you plan, act and review and develop strategies using your practice software to target and continuously improve immunisation coverage. There's resources there to help you. So in summary, here's your checklist. To improve immunisation, we all need to be part of it. We all need to be promoting immunisations. We need to adopt reminder and recall systems. We need to book appointments before people leave. We need to train all staff to check immunisation status at every visit. We need to promote bulk billing for immunisations, including Japanese encephalitis vaccine. We need to have flexible appointment options and provide culturally sensitive material. Like, you may have some families that transport is a real issue, so you may offer them a drop-in day. Just come on this day, we've got a nurse, we'll see you when you get there. Combining these actions create a comprehensive approach in addressing barriers to immunisation. We want to build on our communication skills and foster our community trust. Just in case you've done everything you possibly can, you've used your best communication skills, but parents are still hesitant, don't forget we've got the amazing vaccine hesitancy clinic at the John Hunter Hospital that does telehealth. So Tamworth, Corindai, Armidale, you're not left out. You can still refer people to there, families to there, and they will do telehealth. Together, we've all got a role to maintain and improve immunisation rates for our community. That's all from me. Have an amazing Christmas, everyone. And I'm going to hand over... Oh, sorry, there's all my steps. I'm going to hand over to my amazing colleague, Kirsty. Thanks. I put you up.
Thanks, Jodie. A great presentation. Hi, everyone. So I'm Kirsty. A lot of you would have spoken to me on the phone, I'm sure. I've been around now for a couple of years. So I'm the rural-based CNC of the team. I'm based in Armidale, but I'm very fortunate to be able to come down here to Newcastle to share a presentation. So thanks for joining on a very busy mid-December evening, which I'm sure is busy for everybody with children and end of year celebrations. So we'll just leave this Slido question up for a moment. So how confident are you using the Australian Immunisation Handbook? I'll give you a couple of minutes to look at that. That's great. Really pleased to see that there's a lot of yeses there. There's also some others that need maybe a bit more support. Okay, thanks everyone for the responses. We'll keep moving. I'm just aware of time. So this evening I'm presenting on some travel recommendations. So tips for avoiding vaccine preventable diseases. So there are a few things that fall within the National Immunisation Program schedule that we just want you to be aware of, and that you need to be talking to your patients about if they're talking to you about travelling overseas or around Australia, and just keeping these in the back of your mind. So we'll start off firstly. These are the things that we're going to consider. So measles, and I know it's been touched on previously, influenza, COVID-19 and Mpox. So there's some great resources that are available on New South Wales Health website that go through thinking about these considerations for people travelling. So put these up in your waiting room, particularly around this time of year when a lot of families have potentially time off over the festive season. Making sure that's at the forefront of their mind.
So measles, we all know that it's a highly infectious disease. The catchphrase for measles is measles anywhere is measles everywhere. 9 out of 10 unvaccinated people who come into contact with the virus will contract the illness. Unfortunately, measles has actually had a resurgence in recent years, even in high-income countries that once eliminated it, and that's because the immunisation rates have dropped below 95%. Even when overall coverage is high nationally, pockets of unvaccinated communities with lower coverage rates can leave people at risk and result in outbreaks and ongoing transmission. Now, measles is not a disease that should be thought about lightly. It can be very severe and requires hospitalisation, and there can be some really awful outcomes for people that contract measles. There's an ongoing risk, like I say, across New South Wales and among returning travellers from overseas or interstate due to ongoing measles outbreaks across the world. Now, I'm sure many of you have seen these tiles and information popping up through the sites that you follow through New South Wales Health Alerts. So we get measles alerts fairly, unfortunately, frequently at the moment through New South Wales Health to let us know about cases that have been diagnosed and possibly transmission within community. So that we had some cases just very recently from a few big concerts. And many of you will know that even though high-income countries that you would assume have good access to vaccine, unfortunately are losing their elimination status of measles. So Canada being one that we've just heard about in recent weeks. So unfortunately they have lost their elimination of measles status, and it's looking that the Americas will be very closely following that. So please treat this as important, and there are things that we can do. This slide, I think, is very good to just show you. It's a recent report from the World Health Organization showing the impact that we've had with measles elimination across the world in the last 25 years. So you can see that there was an 88% decrease in measles deaths, and millions of lives have been saved. Now, in 2024, we unfortunately still had 95,000 deaths from measles globally, and that was mostly in our children under 5. And this is higher than in pre-pandemic times. Now, global vaccine coverage has only been 84% just for a single dose, and unfortunately only 76% for 2 doses. Now, we know that the measles vaccine is highly effective, so really important that we are getting those 2 vaccines into people in community. Every death from a disease that could be prevented from a highly effective and low-cost vaccine is really unacceptable. Measles is the world's most contagious virus, and this data shows you once again how it will exploit any gap in our collective defences against it. Measles does not respect borders, but when every child in every community is vaccinated against it, costly outbreaks can be avoided. Lives can be saved, and the disease can be eliminated from entire nations. What can we do? So I'm sure many of you online are very well aware that on their National Immunisation Program schedule, children are recommended to receive 2 doses of MMR-containing vaccine at 12 months and at 18 months. Now, please consider those families that are telling you that they're off travelling and they have a little bub that's anywhere from 6 months of age. They can actually be offered a dose early to provide that protection against transmission and of the virus. So if you see, families in your practice that have babies from 6 months, please do consider giving the first dose of MMR-containing vaccine at that time. Any doses of measles-containing vaccine that's been administered prior to 11 months and 1 day of age are not counted towards the recommended 2 doses, and they should still be repeated. All adolescents and adults that have been born or during since 1966 should either have 2 doses documented at least 4 weeks apart, and both doses over 12 months of age, or serological evidence of immunity to measles, mumps and rubella. Circulating measles virus and disease were very prevalent before 1966. Most people would have acquired immunisation from natural infection. But if you're in doubt in any way, please vaccinate. Now, the MMR vaccine is the one vaccine that is free and funded for everybody in community. Influenza. Influenza, unfortunately, does not go away across the world at all. So clearly, it's generally a winter virus, but there is still circulating influenza in Hunter New England Health, and you can actually contract influenza at any time of the year. However, if you have patients that are telling you they're off travelling to the Northern Hemisphere, please consider giving them a second dose of vaccine before that trip. So obviously a Northern Hemisphere formulation of the vaccine would be preferred prior to travel across to the other side of the world, but that's generally unavailable in Australia. So the Southern Hemisphere formulation is considered an acceptable alternative. Individuals who have received a current Southern Hemisphere influenza vaccine for this season, they usually have had that somewhere from maybe March rather, in Australia. And if they're travelling anywhere between October to May to the Northern Hemisphere, like I say, they are recommended to receive a second dose of influenza vaccine before they depart for that trip. And ideally, this should be administered 2 weeks before their departure to provide optimal immunity. COVID-19. So there is actually no specific recommendation to get a further COVID-19 vaccine prior to travel. However, individuals can receive a dose earlier than the recommended interval in certain circumstances, and that does include overseas travel. So COVID-19 vaccination is recommended for all people aged 18 years and over, and it is funded and recommended for eligible individuals, including anybody without a Medicare card. If you have any questions around particular eligibility, please don't hesitate to reach out to us at the Public Health Unit, and we can help guide you. There has been a recent change in the formulation of COVID-19 vaccine, and so this has recently been published through the Australian Department of Health. So if you have not seen this, that's a link to the poster, and I would advise if you're providing COVID-19 vaccines in your practice or pharmacy, please make sure that this resource is available and close to where your vaccines are stored, so near the fridge somewhere. It's a great guide. Mpox. So Mpox, the Jynneos vaccine is used to protect against Mpox and is free in New South Wales for eligible groups of people. 2 doses are required, and a Medicare card is not needed. Again, if you're unsure of eligibility, please reach out to us and we can help guide you further. If you do have patients that you think are eligible, it is important to offer that vaccine now and refer before the festive season really kicks off. Because as we know, it's our sexual health clinics across Hunter New England LHD that provide this vaccine, and they will be closed over the Christmas New Year period. So they close from Christmas Day the 25th and they will until the 9th of January inclusive. So Mpox vaccines during that time will be pre-positioned at John Hunter and Tamworth EDs, and this is for contact management only. The PHU and infectious disease team will complete risk assessments for contacts and recommend which contacts will require vaccination. But if you have people that you think should be vaccinated and are eligible, please think about referring them to the clinics now. I think we only have about 10 days left until Christmas. Okay, just changing pace now. So part of my role is the school immunisation program coordinator role. I do share that with Lisa. So I'm just going to quickly touch on the program and wrap up as we have finished all our clinics now for the year. So as you know, in New South Wales, we provide or offer two schedule points. We go and see students at school. So year 7, we offer the DTPA vaccine, and within the school program, that is the Boostrix vaccine. Now, if you see a year 7 patient within your service in a pharmacy or in a GP practice, you are able to offer them Adacel. We just cannot provide that in the school program, but Boostrix or Adacel is fine outside of the school program. A single dose of human papillomavirus vaccine is also offered at year 7. Our year 10 students, we offer meningococcal A, CWY. And in particular the Mencodfi vaccine for our adolescents. Now, our school teams do an absolute stellar job of trying to make the most of every opportunity and will offer catch-up vaccinations at every school visit. We have in Hunter New England Health, we have currently 18 school vaccination teams that go out and see our 160 schools across the LHD, and they do amazing work in this space. But some students, some families prefer to take their child to the GP. So please remember about checking vaccination histories when you see these adolescents in your surgery. Unfortunately, as most of us know, and this is not just unique to the adolescent vaccination program, but our rates for vaccination coverage across all of the schedule are declining. And unfortunately, this was a headline in the NC's newsletter just some weeks ago. Adolescent vaccination really has hit a 5-year low. We're currently sitting at about 68% of HPV coverage across the state. We really need to be getting that to 80% and above. So, like I say, our school teams are marvellous and do everything they can, but we really need your help as well. And what can you do? So, when you see an adolescent in your practice, please check their air record. I know Jodie touched on this before, but yes, that was a discussion we had with a family that they were seeing their GP every few months for other things with their adolescent, and they were both overdue year 7 and year 10 vaccines, and it hadn't been picked up. Now, fortunately, this mum phoned us at the PHU, and I said, well, you just need to talk to your GP about this, and the next day those girls were vaccinated and completely up to date. Please discuss the schedule and offer vaccination if it's not complete. Ensure any vaccines administered are uploaded to the air in a timely manner. And have conversations with parents or carers of adolescents. So you may not see the adolescent themselves, but you may have patients coming in saying, oh, my son or my daughter is starting high school next year, or we're just getting them ready to, go into year 10. And at those points, it's really good for you to have conversations with those people and advise them about the program. Don't wait for vaccines to show as being overdue in air. So just making note here that the HPV vaccine does not show overdue on air until 14 and a half years of age. Now that is too late. We want to be offering that vaccine at 12 to 13 years of age. And the reason it's too late, as we know, we want to offer that before any kind of sexual debut. And that does not necessarily mean intercourse. It can just be touching. So this vaccine is amazing, but it needs to be given before that debut. Now, adolescent ACWY is not overdue till 17 years either. So again, our school program, we are really trying to target those students in year 10 who are generally 15 or 16 years of age. Okay, so we're all very familiar, hopefully, with the New South Wales immunisation schedule. And I just want to point out that I think we have a lot of clinicians and providers out there that are really savvy about the childhood schedule. So I'm talking about under fives. And I think that is a requirement because we actually do see those families very frequently in that time. Just remember that that schedule is an all of age schedule and that there is an adolescence box to the side. So it is part of our schedule. And again, it's reminding potentially those families that are coming in at 4 years of age, with their child at 4 years of age rather, and saying, now we finished the childhood part of the schedule. The next scheduled vaccines are due when your son or daughter is an adolescent in year 7. So just making people aware that it doesn't finish when a child is 4. But don't forget about offering influenza. I'll just add in there. Now, HPV dosing schedule did change in February of 2023. So just a reminder, the schedule changed to a single dose of vaccine, and the catch-up has actually been extended to and including 25 years of age. So if you see a young person in your practice up to 25 and you notice on their air record that they have not had HPV, please offer that vaccine. They just need that single dose. The only change to that is if the patient is considered immunocompromised and they are required to have 3 doses. Now that is funded for that group, for everybody up to the age of 25. And then no further doses are needed. If you have any questions at all about the school immunisation program, this is our direct email address, and please, by all means, don't hesitate to contact us. And thank you so much for all the wonderful work you do out there on the ground. I wish you a very happy, safe and Merry Christmas.
Thank you, Kirsty. Some really great and important information, especially heading into summer. So another Slido question is, how confident are you reporting vaccine administration errors? So I'll just give you a minute to answer that question. And if you're not aware, we do like you to report vaccine administration errors. It gives us a chance to provide sufficient education, appropriate where needed, and to follow up also on any adverse effects that might happen from a vaccine administration error. Looking like most people are quite happy to report their vaccine administration errors, which is fabulous. We do love to have a chat with you, so please do report those and we'll be in touch. I am just going to touch quickly on a couple of little topics. It's hot weather. We have those lovely flying bats in Australia. In hot weather, they fall out of the sky. And I know that you are all very kind and generous people and love your animals and like to help the bats that fall out of the sky. We are here to tell you not to do that. So what to do if a person has been in contact with a bat or a monkey or other animals? So it's assumed, or we assume, that every bat in Australia could carry ABLV. So that's Australian bat lyssavirus. It is related to rabies, not the same, but related to rabies. So once someone is actually infected with ABLV or rabies, 99% fatal. So, and in other countries, it's obviously rabies, and that could be all animals, could be a risk of carrying rabies. So we find ABLV in flying foxes, fruit bats, and insect-eating microbats. Apparently some people find these creatures really cute and like to help them, but we like you to use a little bit of caution when you see bats. Either bats that are injured, caught in fences, been attacked by a dog or an animal, or just falling out of the sky. Assume they're infected and don't touch. So we suggest rabies vaccination to people before travelling to countries with rabies. So that's a really good question to ask, adding to Kirsty's about people travelling overseas. Ask where they're going, have a look if that's a country that's got rabies, and offer that vaccine. Obviously it's an expensive vaccine, but please, you need to do your responsibility and actually offer it or suggest it to people. If you're seeing a patient or a person who's been bitten or scratched by a bat and they come in and see you, you need to make sure that wound's been washed for at least 15 minutes and apply some betadine. Really important first aid treatment. You need to record the person's weight, and then you need to contact us or the PHU. So just with that 1300 number, that's a really, really important step, because the PHU are going to assess that person, the risk, the condition that they're in, and we're going to ask lots and lots of questions. So please don't let that patient go home. Make sure you call the PHU or that person is still there. What is the PHU going to do? We're going to do a risk assessment and discuss with the specialist public health doctor the next steps to follow. Where indicated, we're going to make a plan with you about post-exposure prophylaxis treatment. And that could involve rabies immunoglobulin and further vaccines if the person hasn't been vaccinated previously. So this, the immunoglobulin, if you haven't given immunoglobulin before, it can be a little bit daunting because it's actually injected in and around the wound, and we have to inject as much as possible in and around the wound to negate that virus straight away. And then we give some vaccines as well. And this is all on a little bit of a schedule that's going to be worked out by the PHU and communicated with you in a really clear manner. We will arrange delivery of that free post-exposure treatment to hospitals and GPs, depending on where that person is. Usually the next day, but there is some pre-positioned stock supplies at John Hunter Hospital, Tamworth and TAR EEDs, which mean people living close to those areas can access treatment straight away, which is fabulous. Usually that treatment is then completed by their local GP. The PHU will also send a letter confirming the plan and have really good discussions with the treating doctors about what is to follow. And that treatment goes on for 2 weeks. In the last 2 years, Hunter New England Public Health Unit has provided PEP or post-exposure prophylaxis to over 140 patients. So this is a significant issue. I would say it's probably equal with bats and people from overseas, but please don't hesitate to report, even if you're not sure, especially if it's one that's been bitten or scratched by an animal overseas. Please do not hesitate to contact us. I guess the big message is they're cute, but please don't touch the bats. Call Wildlife Rescue instead, and they know what to do. Another question for you. How confident are you in identifying people overdue for vaccines in your surgery? Tricky question following Jodie's presentation about what you should be doing, so let's see how we go. There are lots of different places that you can access information about people who are overdue for vaccines at your surgery. I'm impressed. Most of you are pretty good. Excellent, well done. Let's have a little bit of a look at what's happening next year. A little bit of exciting news. We have a new needle-free influenza vaccine coming. You've probably seen a little bit of information about that. It is a live attenuated vaccine, and it is a nasal spray. So there will be limited doses available in the 2026 influenza program. That's hard to say, isn't it, 2026? Feels like we've only just started 2025. But here it's coming at a rapid pace. This will be available for children between the ages of 2 and under 5 years. There will be limited doses. The program will start in April 2026. Why are we introducing another influenza vaccine? Because the influenza vaccination rates in children aged 6 months to 5 years this year has remained extremely low, 24.4%. So this is, potentially having a needle is a barrier for some people in getting their children vaccinated with influenza, given that we give them so many other vaccinations. So this is another option for people, and it will remain an option for parents. So even though we've had such a small number of vaccinated, this group of children, 0 to 4 years, accounts for 13% of influenza notifications in 2025, with 3,000 presentations to ED and 600 hospital admissions. So that is quite a significant amount of disease burden within that small group. So the more we can do next year to prevent influenza in that young age group, the better we are. So there'll be a lot more information that will come out at the beginning of the year regarding this program. So keep your eyes peeled, and we will be sending that to you through To The Point if you don't already get some information from Ministry of Health. So please keep your eyes out for that exciting program. It will be good. This is a vaccine that's been used in the UK for quite some time, so well safe and tested. So thank you very much from our team. We appreciate everything you do in ensuring that the world is immunised. Have a wonderful break over the festive season, and we hope that you get a lot of rest, relaxation and rejuvenation over the holidays, because we're really excited to work with you again in 2026 and see what we can achieve together. So thank you very much, and I'm going to leave you with a final Slido question before Phoebe takes over. Oh, and we've got one more after that too. So we'll leave this one to run. How confident are you at calling the immunisation register? I'll be interested in this one. I hope you all like the hold music on the air. Start singing. I'm not going to start singing. So it seems like most of you are quite happy to call the register, which is fantastic, because really, if you have a query about somebody's immunisation register record, they're the people to call. Can I just give a little tip in there? If you think that something's not showing on their AIR statement that you've given, please just go onto Proda and actually download their history, open their history at the bottom of their Proda account, because some things will be sitting there as a partially processed vaccine. That means there's something wrong with the dose number, or it's an inappropriate gap between the two different doses of that same vaccine, and that will not show up on your immunisation history statement. So please check that as well. And we'll move on to the final question. How confident are you making general vaccine recommendations, including influenza and COVID vaccines? We have a great lot of people on board this afternoon. Very confident, which is fantastic. Okay, I am going to hand you back over to Phoebe. So thank you very much, guys, for your time. Happy Christmas shopping and have a wonderful festive season. Thank you.
Yay, Sharon. Hi everyone. As always, our wonderful presenters have smashed it out of the park. So thank you so much to them. They obviously have a very, very busy 9-to-5 job, and really go above and beyond creating these presentations and spending this evening with you presenting them. So we really do appreciate it. Thank you to everyone who joined. There was about 180 of us online, which is really great. Appreciating that. I'm sure there are other things you'd rather do, especially in the lead up to Christmas, maybe some last minute panic Christmas present buying, which I will be doing on the weekend. I will turn on the Slido evaluation so you can start filling that out. Won't see you before Christmas, obviously, but I hope you join us next year, because we will get those dates out to you. And celebrate safely with your families. Have a wonderful Christmas period and look after yourselves. Thank you.